So this is just a summary of the case that was just reviewed. And just looking through it at each step after surgery, thinking about how molecular markers might have impacted upon clinical decision-making. We're looking at the surgical pathology features there. And by virtue of the presence of extrathyroidal extension, vascular invasion, and lymph node involvement, by 2009 ATA risk classification, this would be an intermediate risk tumor. And then with the post-op thyroglobulin being 57, both of these features, I think, clinical pathologically justify the administration of post-operative radioactive iodine. Unfortunately, the patient had evidence of recurrence just 1 year after radioactive iodine with a rising thyroglobulin and pathologically proven recurrence. And I just generically put up all the different options I would consider here, and you would notice that chemotherapy is actually not on that list. I think in this setting with localized recurrence, what is of utmost importance here is local control and discrete treatments. I often reserve chemotherapy for settings where the case is clearly palliative, and whether the patient has symptomatic or evidence of radiographic progression, primarily because the administration of chemotherapy is an open-ended venture. Where patients are on continuous treatment, dealing with continuous side effects and toxicities, and is palliative in nature, not curative. And so in that setting, you really have to balance the pluses and minuses of toxicities and benefits. With here, at least, we have discrete treatment options that can achieve at least local regional control. And I think that's really what should be the main focus for this patient. And really, what I was focusing more on was whether or not radioactive iodine or a surgical approach might be considered. Okay. So now, would molecular markers really affect the decision-making at this point? And the basic bottom line here is I don't think so, and no. And first, primarily because the treatment options that one would consider here, even in the context of chemotherapy, are not necessarily molecularly targeted. And then secondly, the markers, we don't really have robust data demonstrating that markers really add any predictive value for any of these interventions apart from what we would use for standard clinical assessments. As was mentioned before, the presence of mutant BRAF portends for a greater incidence of radioactive iodine refractory disease. But that doesn't necessarily add any additional information than perhaps a whole body scintigraphy scan would provide you. And so at this point in the current state of clinical care, and in this particular case, I don't believe that molecular markers would actually add any value. So what I think this does provide an opportunity to discuss, though, is the emerging evidence about the prognostics of these alterations. And how it might have predicted the recurrence that we've seen in this patient. And we've already touched upon many of these points with mutant BRAF. And just to summarize again, it's a very prevalent mutation in papillary thyroid cancers. It is associated with several aggressive histologic characteristics by multiple groups, including lymph node metastases, extrathyroidal extension, and advanced stage. And as was mentioned before, in some studies, but not all, it has been demonstrated to be an independent predictor of recurrence. But in this particular meta-analysis of approaching 2,500 patients, the positive predictive value for recurrence with BRAF mutations is actually quite low. And in the large study published by Dr. Xing and his international colleagues in JAMA last year, what we found was that BRAF mutations can be also associated with increased disease-specific mortality in only the univariate analysis and not the multivariate, which I think really goes to the challenge of using this as a prognostic indicator independent of other clinical pathologic features. Since it's associated with all these aggressive histologic characteristics that have already been incorporated into our risk stratification schemas, the question is there any value at all with mutant BRAF in isolation as a marker? And increasingly, given the proliferation of next-generation sequencing where we can more broadly look at genetic alterations in tumors, the question then becomes can we use this as a prognostic marker in the context of other alterations within the tumor, and whether or not we can also integrate BRAF mutation status as a prognostic marker in combination with other clinical pathologic features. And so this is a slide that Mike Tuttle was kind enough to share with me. And what it really reflects is a continuum of risk associated with specific pathologic features in terms of disease recurrence within the surgical pathology specimen. And this is a figure that's being developed for the upcoming new set of ATA guidelines. And so on the lower half of this arrow are the lower risk disease, and at the top of the arrow is the higher risk disease. And to the right, you can see specific pathologic features that may be associated with this continuum of risk. And what they've incorporated into this schema is the limited, sorry, having trouble with this. Okay. Oh, sorry, there we go. Is the incorporation of these molecular marker mutation testing. And specifically here, we find that BRAF makes an appearance and its mutation status in low-risk intrathyroid papillary thyroid cancers based upon this, by this publication by Rosella Elsai and colleagues demonstrating that BRAF mutations here can be predictive of higher recurrence rates in these low-risk patients. So again, incorporating BRAF as a marker in combination with other pathologic features. So I also want to touch upon TERT promoter mutations, which is another hot topic in the field now. By way of review, telomeres, if you remember, are nuclear proteins that are present at the ends of chromosomes, and they really consist of these hexameric repeats of nucleotides. And every time a cell goes through a cell cycle, these telomeres shorten. And at some point, at some shortened sequence, triggers cellular senescence or cell death. So in this way, the telomeres are really keeping time or keeping track of the number of cell divisions that a normal cell can go through, and is then the trigger for cellular senescence and limiting the number of cell divisions a normal cell can go through. Now in cancer and other diseases, the telomerase complex, which is responsible for extending the length of these telomeres, can be overexpressed or activated, primarily through the overexpression of the catalytic subunit known as TERT. And TERT stands for the telomere reverse transcriptase, which catalyzes the addition of these hexameric repeats to the end of the chromosomes. And so in this way, you've messed with the cellular clock and allowed the tumor to achieve immortalization so they can undergo an undefined number of cellular divisions. And so the big news in 2013 in two back-to-back papers in Science reported the discovery of TERT promoter region mutations at these two cysteines, 228 and 250, which allowed for the creation of new consensus binding motifs and overexpression of TERT. And so this is thought to be now the biologic mechanism by which a subset of tumors can overexpress TERT, increase telomerase activity, and achieve immortalization in cancers. And so recently reviewed in Paula Soares' group where the compilation of the different publications indicating the frequency of TERT promoter mutations occurring in thyroid cancers. And what immediately comes out is that there's an increased frequency of these promoter mutations in more aggressive histologies of disease. And Paula Soares' group has also demonstrated that clinically it can be an independent predictor of persistent disease, distant metastases, and disease-specific survival as well. Several groups have also noted an association between promoter mutations and BRAF mutational status in a positive way. And Dr. Xing's colleagues have just published just even a couple weeks ago in the JCO that the presence of both a BRAF mutation and a TERT mutation can predict for higher rates of recurrence over tumors that don't have either mutation within the tumors itself. So this is an emerging molecular marker that might bring insight into rates of recurrence. And so in this same schema of continuum of risk for recurrence, TERT promoter mutations and BRAF mutations are inserted in here. And so I think I should also bring out the caveat that the purpose of this slide is not to say that BRAF or TERT mutation status should be assessed in all pathologic specimens. This is not standard of care. But in fact, if that information was available, this is at least an early context by which risk assessment can be considered. But in the end, even when you have a sense of more aggressive disease, the question is, does it impact upon clinical decision making? And the question really is no. Even though we know that you have aggressive disease or higher risk of recurrence, there is no prospective evidence that the addition of any therapies will actually mitigate that risk. And so I think one of the things that we have to take into consideration is that these molecular markers represent an opportunity not only to better prognosticate, but also develop new novel approaches for treatment for these patients. And I just want to share very quickly one approach that we are evaluating in Memorial based upon this pilot study we published last year demonstrating that when you inhibit the MAP kinase pathway, you can also reinduce or restore radioactive iodine incorporation in thyroid tumors that were radioactive iodine refractory in the past. And so in this study, we use I-124 PET scans to demonstrate that you can increase iodine avidity in this manner, as well as restore iodine avidity in lesions that were previously negative. And so recognizing the role of MAP kinase activation in this disease and the fact that in a subset of patients in the most difficult setting, this can occur, one of the trials that we're leading internationally, and many of you are participating in, is how we can bring this up front into higher risk patients to help improve the complete remission rate with radioactive iodine after surgery. And here, using a risk stratification schema that Dr. Tello came up with, we've identified patients that are high risk for not going into complete biochemical or structural remission, and then randomizing those patients either to selumetinib or the placebo with postoperative radioactive iodine, and with an endpoint of 18 months complete remission. And this is actually a registrations trial for this drug and is actively accruing now. So moving on to the second case, this is actually a little bit more up my alley since I am a medical oncologist and the kind of cases that I usually encounter. And this patient with metastatic papillary thyroid cancer, and I think the first thing that really struck me was this first observation that BRAF mutation status was not concordant actually between the primary tumor and the metastatic lung lesion. I don't know if that was shared in the slides before, but and in this situation, so when they did Sanger PCR for BRAF mutation status in the primary, it was negative, but positive in one of the metastatic lung lesions. And the reason this is surprising is because I think it's widely accepted now that these MAPK alterations are really tumor-initiating events, and that there really should be concordance between tumor to tumor in terms of BRAF mutation status or RAS mutation status. And in a study performed by Jim Fagan's group, published in 2009, looking at poorly differentiated radioactive iodine refractory disease, indeed, there was almost 100% concordance in this way. When you compare that back to other mutations in other pathways, such as PI3K or AKT mutations, there actually is less concordance, suggesting that perhaps mutations in that pathway are not tumor-initiating events, but actually tumor-promoting events for aggressiveness or metastasis. So in this case, when considering why the lack of concordance here, you could consider, well, it's well established that there is clonal heterogeneity within tumors. Is it possible that there was a BRAF mutant clone within the primary tumor at low allelic frequency that was not detected by Sanger sequencing? And it was shared earlier, these new next generation sequencing platforms with greater depth of sequencing coverage may reveal these lower frequency mutations within the tumors themselves. Or was the metastasis arisen from another focus of cancer within the thyroid itself that wasn't sequenced or detected originally? Ultimately, of course, what's relevant here is the BRAF mutation status within the metastatic lung disease. This is the disease that we're treating in this patient, and the question is whether or not this will influence selection of chemotherapy. And so this is, again, a summary of what was discussed and potential treatment approaches. But in terms of the question for chemotherapy, as I said before, chemotherapy or targeted therapy, however you want to term it, is a palliative open-ended approach, requiring that patients be on continuous, consistent treatment. And so in terms of guidelines for considering when is it appropriate to use chemotherapy or systemic therapy in this setting, I always think about, number one, radioactive iodine avidity. You don't want to leave behind a potentially effective treatment modality if these tumors are still radioactive iodine avid. And you want to be treating it in patients who need it. So patients who have clinical or radiographic evidence of progression or tumor-related symptoms, those are situations where you can definitely measure the benefit of the systemic treatment that you're giving, and of course the performance status and the health of the patient themselves. And so much of the excitement over the last several years in terms of the development of therapies really have centered around multi-targeted tyrosine kinase inhibitors that were really developed to attack the angiogenic processes within these tumors by inhibiting VEGF receptors. They also hit a multitude of other targets. These are rather dirty drugs. But the excitement in thyroid cancer is that these, as single agents in phase 2 studies, demonstrated rates of response. And the banner development last year, presented first in 2013 ASCO and then published more recently in The Lancet, was the results of the Decision trial, which was a phase 3 comparison of sorafenib versus placebo in patients with RAI refractory progressive recurrent metastatic differentiated thyroid cancer. This study was positive for its primary endpoint, which was improvement in median progression-free survival from 5.8 months in the placebo to 10.8 months with sorafenib, and ultimately led to FDA approval of this agent in November of last year, making it the second FDA-approved agent for thyroid cancer, the first being doxorubicin. I also include here the response rate data because in the end, although progression-free survival was improved, the response rate was quite modest still, around 12% or so, and much of the benefit was really in stabilizing patients' disease. So again, if you recall the cases that we were just reviewing, this is a very effective maintenance type of therapy for increasing patients' progression-free survival duration. But in terms of dramatic shrinkages of tumor at particular sites, this may not be as an effective approach. But the other exciting development was presented this year at ASCO, and that was the results of the SELECT study, another phase 3 study of thyroid cancer, evaluating another multi-targeted tyrosine kinase inhibitor known as lenvatinib. This was again a comparison to placebo, and like sorafenib and other agents in the class, hits a multitude of targets. And what makes lenvatinib a bit unique is that it also inhibits targeted FGF receptors 1 through 4. And here are very impressive results. The primary endpoint for this study again was PFS, and with lenvatinib it was an 18.3-month PFS versus 3.6 months with the placebo. And if in the trial-to-trial comparison, longer than what was achieved with sorafenib. Here is the waterfall plots where, if you're not used to looking at this, on the y-axis demonstrates the largest reduction in tumor size seen in each patient. And as you can see, almost all patients had some degree of tumor reductions and an extremely impressive response rate of 65%. What was also impressive was that in this study, they allowed patients who had been previously treated with VEGFR targeted therapies, and the benefit in progression-free survival was preserved among all these, whether or not you used it in the first or the second line. And so the current status right now is the development of these drugs gives us new treatment options for patients, and that mutation analysis does not impact upon the use of these drugs. And in the interest of time, I'm not going to go into the other experimental approaches, but I think the role of molecular markers for selection of chemotherapy are really in experimental phases, where we're utilizing different approaches to target BRAF mutations with BRAF-targeted agents and other MAP kinase interactors, and those trials are ongoing. So I'll just stop there.
Thank you.